Okay, hello, good afternoon, good evening. Welcome to CPD webinar series hosted by Mansoor and Ali, who is a consultant renal physician, and myself. We host these webinars once a month. Today we have two speakers. First speaker is Dr. Farooq Mahmood, who is a rheumatology consultant in Bradford Hospitals. And he's going to talk about polyarthralgia, very important topic. We see it every day in acute medical units and ward rounds. And the question is when to refer when you see a patient with multiple joint pains, arthritis, arthralgia. So over to you, Dr. Mahmood. Thank you.
Thank you very much. Thank you for your introduction. First of all, just to check, everybody can hear me okay? Is that okay, Mansoor? Everything okay?
Yeah, everything okay?
Yeah. All right, brilliant.
Yes.
Okay, brilliant. And my presentation is on there as well. So my name is Dr. Farooq Mahmood. I'm one of the consultants, and I've just started at Bradford Teaching Hospitals. And Mansoor invited me to the webinar to speak a little bit about polyarthralgia and when to refer to rheumatology. Obviously, we've only got 20 minutes or so it's not going to be an exhaustive look at all the causes of joint pains and how to manage everything. That would be far beyond the scope of what you need to know and beyond this talk, but it's just to give you some general primers so that you would be a bit more informed about when you would have to be suspicious about certain joint pains and they will need to be referred to rheumatology, or when they need to go to orthopedics or to other specialties, for example. So hopefully this will give you a bit of a clearer idea about joint pain in general and about how to interpret blood tests such as rheumatoid factor and anti-Ccp if you're worried about rheumatoid arthritis. So my aims are, we'll talk a little bit about, as I've mentioned before, about joint pain and polyarthralgia and polyarthritis. I'll talk a little bit about the things you need to look for in a clinical assessment of these patients, which investigations that you should do if you're worried about an inflammatory arthritis versus a mechanical arthritis, and then obviously when to refer. There'll be a couple of case reports as well, just to illustrate what I've spoken about, and then we'll finish on some key points. So as I'm sure most of you are aware, joint pain is very common in the population. At most point, we're all going to suffer from joint pains if we haven't already. And there's one American study which shown that 1/3 of the general population in North America have experienced joint pain at some point of their lives, according to one survey that was done. So obviously very difficult to shift out which patient should go to where. You don't always have time to try and find out when you're in a busy ward or in a busy general practice. Somebody presents with joint pain or someone's complaining of joint pain, they might have come in with another medical issue and you're not entirely sure, you don't always have the time to try and find out where they should go and whether it's something you need to be worried about or not. And osteoarthritis is a very common cause of joint pain. We're all going to suffer from osteoarthritis, unfortunately, at some point in our lives, as it's more prevalent as we get older. There's no cure for our skeletons getting older, our bones getting older. And recognizing which should trigger a referral to rheumatology when a patient is complaining of joint pain can be very challenging. And it's something that needs a lot of experience as well. When we talk about polyarthralgia and polyarthritis as rheumatologists, those are two different things. So when we refer to polyarthritis is multiple joint pains and objective swelling. Now, most patients in our experience as rheumatologists or looking at referrals, some of these referrals we sometimes get from general practice, for example. Nowadays, obviously, you can't see the patients, you just talk to them. Patients saying, we've got joint pain, we've got joint swelling. But subjective joint swelling isn't the same as objective joint swelling that a clinician can find on examination. So that's what we mean by polyarthritis. When we talk about polyarthritis, we mean multiple joint pains and objective swelling. Polyarthralgia is multiple joint pains without joint swelling. And both of them you'll come across in terms of your practice. Polyarthralgia may be more common though. That might be the more common type of joint pain that you come across, as most people might suffer from joint pains, but they might not have an inflammatory cause. They may have another cause of that joint pain, and we'll explore some of that today. So really what you need to identify when a patient is complaining of joint pain, we need to know two things. Is it inflammatory or is it mechanical? Because that's what's going to help you decide where you're going to refer these patients onwards and which ones will need further investigation. So before you do, you think about, where you want to refer, as in with any symptom, you want to find out the pattern of that symptom. You want to find out more information and more detail about that symptom. So particularly with joint pains, you want to know which joints. Is it a joint as in a monoarthritis or a monoarthralgia, or is it poly? Is it many joints? Is it pain or swelling or both? So that's an important thing as well. Patients complain of joint pain, but they might not have any identifiable joint swelling, so they've got a polyarthralgia. They may be complaining of joint pain, but they've got multiple joint swelling, so then you've got a polyarthritis. Pattern is very important. So inflammatory joint pain characteristically is worse in the mornings, and it's worse before activity. So it tends to be worse at rest. Whereas mechanical joint pain tends to be worse towards the end of the day, throughout the day, and in the evening. And along with that, what is that relationship to activity? Inflammatory joint pain characteristically is actually better with activity. When people start using their hands and feet, they actually find the joint pains aren't as bad. But when they've got mechanical joint pains, they find that it's worse, particularly after activity. They find that their pains are very excruciating after that as well. Early morning stiffness is a very cardinal feature of patients who have inflammatory joint pain. So early morning stiffness of up to 1 hour is something that should raise suspicion that a patient might have an inflammatory type of arthritis. And when we mean by early morning stiffness, these patients, some of these patients, young patients who are in their 20s and 30s, are unable to actually get out of the bed. They're almost paralyzed because they're so stiff in the mornings. So early morning stiffness is a very cardinal feature. And if you come across a patient that's complaining of several hours of early morning stiffness, and they're really struggling to get out of bed, that should trigger in your mind, maybe I need to get rheumatology involved, because there might be an inflammatory cause of their joint pains. Early morning stiffness is it's a very uncharacteristic feature of mechanical. It's more of an inflammatory type feature. And of course, as I'm sure most of you would be aware, systemic symptoms would be much more likely to go along with somebody who's got an inflammatory sounding joint pain. So for night sweats, rash, weight loss, these are things that young patients who suffer from rheumatoid arthritis or middle-aged patients can suffer from. And you should start thinking about whether this patient has got an inflammatory joint pain. Mechanical joint pains don't characteristically give patients systemic symptoms. So they tend to be just located, the symptoms is located to the joints which they're suffering from.
Farooq, can I just actually ask you, if you don't mind? I think.
Yeah, go ahead.
Could you just zoom out of your slide, because we were not able to see the whole slide. I think we're just kind of actually seeing. I think would it be possible just to zoom out of your slide slightly?
Yeah,
maybe kind of actually if you. It's just too big. We're just literally seeing one.
Also, I can see the whole slide.
Can you see the whole slide?
Okay. I can see that.
Yeah. As long as you can, everyone else can see the whole slide, because I can't see the whole slide. It's just actually literally, I can just see 1 or 2 bullet points. Maybe it's my setting, but that's.
Is it your settings?
I can see slides as well.
That's fine. Excellent. If you all can see, that's fine. It's probably my setting. Go ahead, Farooq. Sorry about that.
Are you sure? Okay. All right.
Yeah, go ahead.
Sorry about it. Yeah, I wasn't sure how to zoom out, but
yeah.
Okay, so
that's fine.
The key, as I said, the key is to establish between inflammatory and mechanical causes of joint pain. And if it's inflammatory, then obviously rheumatology will need to get involved at that basis, because that's when we would come in, if it's inflammatory joint pain. If it's mechanical joint pain, then there'd still be a bit of work about, what would be causing the joint pain. And it's really trying to identify the underlying cause of that joint pain and what the cause of that mechanical joint pain is in arthralgia. And that's when you would start thinking about these other teams that you would need to refer to. Certainly, if you're suspicious that's inflammatory based on what we had just talked about, you've taken all those features in the history and you're convinced that this is inflammatory joint pain, and that's when rheumatology should get involved. So going on from the history taking, obviously the next thing is clinical examination, and that's inspecting the joint or joints for these characteristic features. So we're looking for pain, we're looking for swelling, any warmth. Warmth is obviously a feature of an inflammatory joint pain, and also joint distribution. What kind of pattern is it as well? A single large joint, which is very tender but not particularly swollen, or is a very hard swelling, not a boggy swelling. That would be more of an osteoarthritis, or more of a mechanical type of joint pain. If it's multiple small joints in the hands and feet, which are swollen, they're very warm to touch, and they're very boggy swelling, so they're suggestive of synovitis. That's suggestive of inflammation in the synovium, which would make you think of an inflammatory arthritis. So clinical examination is always very important as well, and that will give you clues as to what type of joint pain it is, whether it's a mechanical joint pain or an inflammatory joint pain. So investigations, X-ray of the affected joints are always very useful. That would tell you whether they've got features that would be consistent with an inflammatory arthritis. That can sometimes be a bit subtle on X-rays, but you can pick it up. Or whether it's mechanical. Obviously, you could look and see if there's wear and tear that'd be consistent with osteoarthritis. or whether there's an infection in the joint, for example. So X-ray is always very useful to get for the affected joint. Wherever you're thinking of referring the patient onto, whether you want to refer them onto rheumatology or you refer them to another specialty, we would always be very appreciative if they've had some X-rays of those joints done first. It's always useful to get X-rays of the joints. If you're suspicious that this is an inflammatory joint pain, then you would ask for rheumatoid factor and anti-Ccp antibodies. And these are antibodies which specifically we would look for in patients who may have possible rheumatoid arthritis. And I'll talk about these a bit later on during the talk, so we'll talk about this a little bit more. And obviously inflammatory markers such as C-reactive protein or ESR, depending on where you work, which hospitals you work, which trusts you work, they might have different types of inflammatory markers, but they're always very useful as well to check to see if patients have got raised inflammatory markers, which could point you towards which type of joint pain they've got. So rheumatoid factor and Ccp antibody, I just wanted to talk a little bit about this. So very helpful to establish diagnosis of rheumatoid arthritis. However, this is where requesting tests and interpreting tests becomes an art, because it needs to be requested in the correct clinical context. So I would not recommend that patients should have a rheumatoid factor anti-Ccp if they don't have inflammatory features in their history or examination, because it's very difficult to interpret then if they do come back mildly elevated, like you would see in other diseases and other conditions. It muddies the waters if they do come back positive, but they've got a mechanical joint pain. Then it's unclear how to interpret that. And it doesn't mean if it comes back positive that they've definitely got rheumatoid arthritis. So you have to be a bit wary about requesting these. It was always about requesting tests in the right clinical context, in the right setting. So if they've got inflammatory features in the history and on examination, and you are worried they've got rheumatoid arthritis, then I think requesting both rheumatoid factor and Ccp is very useful. But if you're not so certain, or if you think it's much more of a mechanical, then I would recommend not doing rheumatoid factor or Ccp. Rheumatoid factor especially can be elevated in other conditions as well. So it's not just in rheumatoid arthritis you can get an elevated rheumatoid factor. So a rheumatoid factor can also be elevated in multiple other conditions as well. So chronic liver disease and primary biliary cirrhosis, certain types of viral infections can also produce a positive rheumatoid factor. You can get it raised in endocarditis and tuberculosis and other more rare conditions. Sometimes sarcoidosis can produce an elevated rheumatoid factor as well. And we've seen sexually transmitted infections such as syphilis and hematological malignancies such as leukemia can also produce a raised rheumatoid factor as well. So it can be elevated in other conditions as well as rheumatoid arthritis. So you always have to be cautious about how to interpret it, particularly in patients, particularly in inpatients who may have come in with some of those diseases. For example, you do a rheumatoid factor and they come back elevated. It's very difficult to interpret it, particularly if the history is not particularly going towards an inflammatory cause. Ccp antibody is a bit more specific for rheumatoid arthritis. It tends to be more raised in rheumatoid arthritis than in other conditions, like we've seen in the rheumatoid factor. And it can be raised in patients who have no joint pains. It can be a predictor of developing rheumatoid arthritis later in life. For example, it can be a prognostic marker as well. However, again, would not recommend testing it if the patient does not have clear inflammatory features. There have been studies that have shown that up to 1% of the normal population can be CCP positive, but that does not necessarily mean that they've got rheumatoid arthritis or will develop rheumatoid arthritis. They could just have a mildly raised CCP antibody. So again, it's all about requesting these in the correct clinical context. There is some research ongoing in Leeds, actually, where I've trained, which is specifically looking at CCP positive arthralgia. So it's looking at patients who are complaining of joint pain without features of rheumatoid arthritis, but they've done a CCP antibody and it's come back positive. And they're following these patients up to see when are they developing rheumatoid arthritis and should they be treated with disease-modifying agents before they develop the features of rheumatoid arthritis. So you've got a patient who's got joint pains, but they've got no joint swelling or no early morning stiffness, but they're mildly CCP positive. Should we give them methotrexate before they go on and develop rheumatoid arthritis? Would that help prevent the development of rheumatoid arthritis? That research is still ongoing. So there's still no guidance for that as yet about how to treat these pre-RA patients, these pre-rheumatoid arthritis patients. So if you've got patients who don't particularly have any features of inflammatory joint pain, they're complaining joint pain, but it's not particularly inflammatory, then I'd be very cautious about requesting doing a CCP antibody. So if you have a patient on the ward that you're more concerned that may have a mechanical cause for their joint pain rather than an inflammatory cause, They're very common causes of patients in the community or in the ward that may have multiple joint pains. One of the most common causes, as I'm sure most of you will be aware of, both joint and body aches is vitamin D deficiency. And we see it quite a lot in rheumatoid. We still get a lot of patients, and it turns out they've got very severe vitamin D deficiency. And that's the reason why they've got joint pain and muscle pain. So it's always very important to check that. It's always very important to check thyroid. Thyroid can produce thyroid dysfunction, such as hypothyroidism can cause joint pains or lead to joint aches. Patients can have fibromyalgia and chronic pain syndromes. In particular, patients who've got lots of soft tissue tenderness as well. So they're not just tender around the joints, but they're tender in all of the soft tissues. It may be more of a fibromyalgia and chronic pain. Chronic pain syndrome, you can't find an underlying cause for the joint pains, but it's not inflammatory. And these patients, we don't tend to see in rheumatology. They tend to get referred to chronic pain teams or pain specialists, anesthetics, who deal more with their pain better. Infection, so as well as causing a reactive arthritis or an inflammatory arthritis, just a generalized infection can cause an arthralgia, can cause joint pains as well. It doesn't mean they've got an inflammatory arthritis or rheumatoid arthritis or reactive arthritis. They can just feel generally unwell, and they can get joint pains as a consequence of being unwell with sepsis or an infection as well. Injury, previous injury can lead to secondary osteoarthritis, and they can get joint pains in that joint. And just muscle deconditioning. And we actually see this a lot in patients who have been in hospital for a very long time, and they've become very deconditioned as a consequence of being in hospital bed. They've been unwell for a long time, and they can develop tendinitis and joint pain secondary to that as well. So these are some of the common causes of polyarthralgia. Important things to think about when you're assessing a patient, either on the ward or in the community, particularly with vitamin D, thyroid, and fibromyalgia in the community. And on the wards, you might think about, is it the underlying cause of their joint pains just because they've come in with an infection, or is it because they've been in hospital for a long time and they've developed muscle deconditioning? So just a brief word on management as we wrap up. Identify and treat the underlying cause, correct any underlying deficiency that you find, such as vitamin D deficiency. Physiotherapy is obviously very useful in anyone that's complaining of joint pain or muscle deconditioning. It's always important to warn patients that physiotherapy is not a miracle cure overnight. Physiotherapy is something that will take some time to cause an improvement. So it's always managing patient expectations. Anti-inflammatories you can use in either mechanical or inflammatory joint pains as well. You can use them in mechanical joint pains. Naproxen, eterocoxib, and celecoxib if there's no contraindications. But you can follow the WHO analgesic ladder, which is very easy to reference. If they've got quite significant osteoarthritis and affecting one joint, then often they might need referral to orthopedics to consider a surgical opinion rather than rheumatology, because there isn't much that we're going to be able to do for that joint. It would have to be a surgical opinion in that case. Unless you've got evidence of clear inflammatory disease, then I would avoid use of oral steroids in patients who are complaining of joint pains. Intra-articular steroids can be useful in both inflammatory and mechanical joint pain if it's osteoarthritis. But the caveat with that is it may not work as well in patients who've got osteoarthritis, and particularly in severe osteoarthritis. But certainly in inflammatory joint pains, we do use steroids, both oral and intra-articular. So just some case reports to illustrate what I've spoken about. This is a 37-year-old male, and he presents with symmetrical onset of joint pain and swelling in his PIP and MTP joints, so both in the fingers and the base of the toes, for the last 6 months. It comes on fairly gradually in inflammatory arthritis. Indolent, a progressive history, has been getting progressively worse, associated with early morning stiffness of 1 hour. Pains are worse in the mornings and before he does any activity, worse at rest, and better with activity. And there's also a family history of inflammatory arthritis, because these can cluster in groups as well. So this is quite a typical history that we would see in somebody who's got a history of rheumatoid arthritis. Histories in favor of inflammatory arthritis, you would check inflammatory markers, you check rheumatoid factor and Ccp antibodies, x-rays of hands and feet, and you'd refer to rheumatology. So those are the sort of the baseline investigations that you can do, and then you can refer these patients on to rheumatology, because it does sound like they've got an inflammatory arthritis. This is a patient who's got osteoarthritis, 65-year-old female, 3-year history of worsening left knee pain. It's worse for activity, so climbing up and down stairs or going for long walks, classically. It's worse in the evenings, and it's also nocturnal, can wake patients up and can be throughout the night. The joint swelling can be intermittent, and they get joint locking with it as well. So locking is a sign in one joint that they've got quite severe osteoarthritis, and that's usually an indication for surgery if it's interfering with their activities of daily living. Again, history is suggestive of osteoarthritis. They don't need a rheumatoid factor CCP antibody checking. X-ray of the joint would be recommended. We would consider referral to, we would advise referral to physiotherapy. And then if it's joints that are, such as the knees or the feet, you refer to orthopedics. If it's the hands and they've got osteoarthritis in the hands, then it's usually plastics in some hospitals that would take over that. And just one final slide, just one final mention. This is just talking about seronegative inflammatory joint pain. So patients who you're worried that have got inflammatory joint pain based on their history and examination features that we talked about, but the rheumatoid factor and CCP antibody is negative. So there are causes of seronegative inflammation as well. And some of the causes are listed there. So psoriatic arthritis, crystal diseases, reactive arthritis, spondyloarthropathies such as ankylosing spondylitis, inflammatory arthritis associated with inflammatory bowel disease, or reactive type infection type arthritis, or other types of connective tissue disease apart from rheumatoid arthritis, such as lupus and Sjogren's syndrome. The key is the history and examination findings. If you're still very concerned that this is inflammatory joint pain based on your history and examination, although the rheumatoid factor and CCP antibody is negative, it still would be appropriate to refer to rheumatology if you've got any concerns that this is inflammatory on the basis of the history and examination that you've taken, because of some of these other causes that can cause seronegative inflammatory arthritis. So the key point, joint pains are very common. We're all going to suffer from joint pains at some point in our lives. The key is to distinguish between inflammatory and mechanical causes of joint pain. If you're concerned that it is inflammatory, then a rheumatology opinion is recommended. If you're concerned that this is more of a mechanical cause, then you have to find out and do some more investigation to find out what the underlying cause of that is, and then either treat that cause yourself or refer on to the appropriate team, if it would be orthopedics or another team that would look after that particular body area. Just have caution about requesting and interpreting the rheumatoid factor and CCP antibody, particularly in patients who don't have joint swelling, objective joint swelling, and they've got more of a polyarthralgia. If, however, you are still concerned that they've got an inflammatory sounding joint pain, then getting an opinion from rheumatology, we're always happy to discuss and talk with any medical team, our medical colleagues. Okay, well, thank you very much. And these are some of my references.
Thank you very much for this talk. So
thank you very much for excellent talk. Thank you.
Thank you. Thank you for inviting me. Thank you.
Thank you. So speaker, we have Dr. Akbar Mahmood, who is a consultant renal physician at Bradford Teaching Hospital, and he's going to talk about calcium, phosphate, and parathyroid management in CKD.
Thank you. Akbar, are you ready for the slides? Can you share the slides? Dr. Mahmood? Akbar? Can you unmute yourself, Akbar?
Yes. Wait a second, Mansoor. I'm just trying to
Thank you.
Open my presentation. And then I think next step is screen sharing.
Yeah, that's right.
Can you see my slides?
Not yet, no. If you want to share.
Not yet.
Naseem, is Akbar?
I've made you a host, Dr. Mahmood, so you should be able to share it. You will see the share screen green button at the bottom. I've made you a host, so you should be able to share it now.
Yes. Can you see the slide?
Yes, we can now. Thank you.
Yes, we can see.
Okay, thank you for giving me this opportunity to present a talk on Ckd Mvd, like chronic kidney disease associated with bone mineral bone disorder. So I'll start my discussion with the clinical case. its management, what is the evidence-based approach, CKD MVD relationship with PTH, and identifying the different components of CKD and MVD, and what are the long-term impacts of CKD on bone health and management challenges. What should be the critical thinking to improve the bone health of a chronic kidney disease population, and what is the future? So it's a busy slide, sorry for that. This is a known end-stage renal disease patient on peritoneal dialysis for the last almost 5 years, with a background history of fractured knee joint with open reduction internal fixation, and he was referred to us for consideration of a kidney transplant as a definitive treatment of choice for our end-stage renal disease population. And while he was referred to me, like in our unit, and I was the one to first see this patient. So he was on peritoneal dialysis. Medications include sevelamer, cinacalcet, metoclopramide, because he was having a nausea and vomiting due to big dose of cinacalcet and darbepoetin, carbimazole, and phenolphthalein. So as I mentioned, he was in CAPD. I will not go into details. And he was hemodynamically stable, euvolemic, and uric, and clinical examination was unremarkable, and his BMI was 17.3. This is slide showing anemia, hemoglobin of 9.1, and this is a slide showing the alkaline phosphatase from the baseline workup which we did for him. It was showing alkaline phosphatase 340, which is above the normal limits of 129. And
Dr. Mahmood, can you speak a little bit louder, please? Because some people can't hear you. Can you speak a little bit louder, please?
Can you hear me now? Is it, my voice is okay now?
Yeah, this is a bit better.
Yeah, if you could just come slightly closer,
that's a
because
bit
we can't hear you. Thank you.
Okay. And serum adjusted calcium 2.1. So in this slide, I have presented two problems: high alkaline phosphatase and lowish corrected calcium. This is a slide of PTH. When we see the right hand side, there are two readings. One is 443 and the second PTH is 256, like 257. So these are the two readings when we presented to our unit, and during the baseline assessment, we found that he has a severe hyperparathyroidism while he was having end-stage renal disease. Later two readings I will discuss. On the right hand side, there are two readings which I will discuss or mention later on. This is a slide which is showing that along the bones, if you see that there is a calcified tube, so these are the calcified blood vessels. So these are showing that CKD, advanced CKD population is at risk of calcium deposition in the blood vessels and the other organs. So based on the based on the presentation and high alkaline phosphatase and this calcium deposition in the blood vessel, we rather planned to do a transplant workup. First, we thought that we should evaluate his parathyroid status, and clearly he was having a tertiary parathyroid hyperparathyroidism because of the advanced CKD. And this is an ultrasound of the parathyroid gland, and this is a SPECT images of the parathyroid gland as well. And when we did osteoporosis DEXA scan, it showed he had a severe osteoporosis. And this is a scintigram. And on the extreme right hand side of the image, this is a normal scan, and the left side image is the scan from the patient, and we can see clearly that there is a radiotracer uptake in the area of head and mandible region. So they call it a super scan, which is consistent with the too much activity of parathyroid hormone. So as I showed you earlier, so this is summary slide that his best PTH was more than 400 extra osteoporosis, and then there was a centigram uptake called superscan. So at this point of time, rather proceeding to a transplant, a renal transplant workup, we made a conclusion that this man is suffering from the severe renal hyperparathyroidism, and this comes into the umbrella diagnosis of chronic kidney disease, mineral bone disorder, and this could be a diffuse parathyroid hyperplasia, and this could be a parathyroid adenoma, carcinoma, whatever it could be. So, so we involved the parathyroid, and he was already on a medical management. Cinacalcet is a drug which we use in a dialysis population to manage hyperparathyroidism. But despite on Cinacalcet, he first of all he was having a nausea, which shows that he was intolerant to this drug, and despite this drug, parathyroid gland activity was uncontrolled. So medical management has failed, and so we proceeded with this surgical management, and that is parathyroidectomy. So this is a slide where surgeon took the consent from the patient, highlighting the points that what could be the risks involved in the surgery, pre-op, peri-op, and post-op, like voice changes, hungry bone syndrome. Patient needs central line access to replace loads of calcium and electrolytes. And if it's a like a parathyroid carcinoma, then we may proceed further with the oncology input. And maybe if we must tell the patient that we may proceed a second surgery at some point in the future, because there could be a recurrence of the remaining remnant tissue, wound-related complications, hematoma, scar, keloids, and infections, skin flap, paresthesia. So these are the common things which we need to inform to our surgical patient, and we explain to that man. And he consented for the surgery. So as you see, this is surgical field, a picture of the patient taken during the surgery, and P is the parathyroid and T is a thyroid gland. Now you can see the parathyroid gland is a bit darker. When this gland is exposed to the skin, it changes color a little bit. So he underwent subtotal parathyroidectomy, and post-op his blood pressure was a little bit high. We managed it pharmacologically, and second problem post-operatively we faced was potassium 7.4. His adjusted calcium was 1.69. ECG was not showing any hyperkalemic change. So we have already informed the patient that we will continue peritoneal dialysis, but if peritoneal dialysis fail to manage this hyperkalemia, or if there is an emergency situation, then we may shift the patient to hemodialysis, because hemodialysis is a better modality to address acute hyperkalemia. So again, this is some slide, but I have just spoken on 12th post-op day. We were able to discharge this patient successfully, but during the hospital we received a lot of calcium in the high dependency unit. As I mentioned earlier, that these patients developed hungry bone syndrome, and he was discharged home with a corrected calcium of 1.9, asymptomatic. And this is a histology report of that patient, which showed no parathyroid adenoma, but a nodular parathyroid hyperplasia, which is very much related, and this is a classical finding in a dialysis population who are on dialysis long term and who develop hyperparathyroidism. That's why we usually don't use the term tertiary hyperparathyroidism. We prefer to use renal hyperparathyroidism in such population. So again, as I mentioned, this is a discharge prescription, loads of calcium, vitamin D supplements, and antihypertensive therapy. So Ckd, Mvd, and effects on skeleton. It's a picture from JAMA in 1980. You can see the same person on the left side. This person is with a normal height, and you can see the same man developed renal failure. He was on like renal failure treatment, including dialysis, but at a point, time came that you can see that he has shortened his height and see this bone. That the same individual with drastic changes in his height because of the skeleton under threat due to hyperparathyroidism. Again, another patient, you can see the same person because of the renal hyperparathyroidism, there is a change in the height and the body stature. So basically, this is a policy slide. We can see that when the EGFR falls, so few hormones are important to play a role into the regulation of the kidneys, bone, musculature. So when EGFR falls, Clotho and FGF fibroblast growth factor plays a role, and then ultimately vitamin D, and then PTH and the serum calcium level, they all act interchangeably. This is my paper which I published in Journal of Nephrology and Renal Therapy about 2 years ago on the topic of mineral bone disorder. So to understand this topic, so KDIGO has come up with a very beautiful classification. We call it TMV classification. T stands for turnover, M stands for mineralization, and V stands for volume. So we categorize the bone health or a bone problem into 3 categories: turnover diseases, mineralization defects, and volume disorder. So turnover means osteitis fibrosa cystica, which is the hyperactivity of the PTH, like secondary or tertiary hyperparathyroidism, and adynamic. The other spectrum is adynamic bone disease, which means the PTH is underactive and there is no turnover or a very reduced bone turnover. Second category is a mineralization defect. We call it rickets in the children and osteomalacia in adult population. And the third category is volume disorder like osteopenia and osteoporosis. Osteopenia, weak bones, and osteoporosis means severely weak bones, calcium, vitamin D, and bisphosphonates. So again, the pictorial representation of the same thing: high turnover disease, low turnover disease, and abnormal mineralization, which is associated with CKD. This is a structure of fibroblast growth factor FGF23, which plays a very important role in the bone health associated with CKD. So busy slide, but it's an important one to know what is FGF23. So it is a hormone which is produced from the osteocytes in response to high phosphate, and phosphate becomes high when there is a established renal injury, and this hormone FGF23 plays a role as phosphaturic hormone, just like PTH. And this is the first hormone to go up to normalize hyperphosphatemia in a CKD population. But FGF23 does not act alone. To establish effect of FGF23, it needs a co-hormone, which we call it clotho. So basically, clotho is a word derived from the Greek goddess of life. In the latest medicine, Q10 enzyme is the medicinal formation of this coenzyme hormone. So FGF23, as I said, is the main factor causing low calcitriol based on the reduced renal and reduced nephron mass.
Dr. Mahmood, you have 2 minutes.
Reduced calcitriol causes stimulation of PTH, then
Dr. Mahmood, you have 2 minutes left.
so okay. So low calcitriol levels associated with reduced vitamin D receptors within the PTH gland, which causes continuous hyperactivity of the gland, and this continuous hyperactivity transforms parathyroid gland in nodular hyperparathyroidism. The same mechanism which I have mentioned. Again, this is FGF23, which is associated sometimes with oncogenic osteomalacia. This is produced from a malignancy. So another regulator is the calcium. So calcium change in ionized calcium is sensed by the calcium sensing receptors in PTH, and these receptors are also present like other parts of the body as well. So in nodular parathyroid gland, the calcium sensing receptors becomes insensitive. So PTH becomes autonomous, and due to advanced CKD, there is a high calcium phosphate product, and which results into calcification and related problems like calcification in the vessel and calcification in the heart valve. The same thing. So a key to calcium homeostasis by regulating PTH is in 3 ways, like synthesis of PTH in response to low calcium levels, then secretion of PTH, and then proliferation of parathyroid cells. So again, this is a role of PTH to maintain calcium homeostasis in the body. And
Dr. Mahmood, you have 1 minute.
okay, so this this is a slide which shows once calcium is low, how PTH mobilizes the calcium from the bone and gut. So this is a interactive role of parathyroid, bone, and the kidneys. So these are the few slides which are showing some deleterious effects of continuous hyperparathyroidism. And these are the features you can see in an advanced dialysis population whose PTH hyperactivity is missed. So they come up with a brown tumor. So again, the same cartoon which is depicting how the nephron, bone, PTH, and gut is playing the role. And these are the few slides. And this role of Senecalcet is very much indicated in the CKD population. And NICE guidelines does recommend Senecalcet, but if we are in a situation to handle this PTH, recommendations are to go for parathyroid surgery. It is cost effective as well as compared to Senecalcet. Again, this is the United States Renal Data System Registry. They propose parathyroidectomy as a preferred option if someone is proceeding to a kidney transplant and whose PTH gland is uncontrolled, like autonomous. So to conclude this discussion, it is recommended to ensure bone health in a CKD population, and because calcium, phosphate, vitamin D, PTH, FGF22, and clotho play a very interactive role, and bone turnover is very important. Bone turnover is very important to monitor during our dialysis rounds and seeing CKD patients in our clinic.
Okay, thank you very much, Dr. Mahmood. Thank you. I know I've seen your slides, 60 plus slides. I wish we could have actually had more time, but thank you very much. That is really interesting. And I'm sure there'll be lots of interesting questions to be asked. So the audience, please, I hope you've actually got some understanding of Ckd Mvd and also polyarthralgia. So we've got some questions already coming in. I've got a question for Dr. Farooq Mahmood, to start with you first. And this question has come from my colleague, Dr. Naseem Naqvi. How sensitive and specific is anti-CCP for rheumatoid arthritis diagnosis? Thank you, Farooq.
So it's, according to one study, it's 70% sensitive and 85% specific, the anti-CCP antibody. CCP antibody is also a good prognostic marker as well. So if you're CCP antibody positive and with a diagnosed rheumatoid arthritis, you're more likely to develop extra-articular manifestations such as rheumatoid lung disease. And you're also more likely to develop erosive joint disease as well. So CCP is a vitally important antibody to check. Up to 60% of patients are CCP positive when they're first diagnosed with rheumatoid arthritis, and up to 75% will develop a positive CCP within the first 2 years of diagnosis as well. And it's present in up to, like I said in the presentation, 1 to 1.5% though of the normal population might have a mildly elevated CCP. But it is it's certainly more specific than a rheumatoid factor would be.
Thank you very much for really well explained and a clear and concise answer to that. Dr. Mahmood, Akbar Mahmood, you've got a question from my colleague, Dr. Naseem Naqvi, and this is, does tertiary hyperparathyroidism always require surgery? But I may want to kind of actually add something to this. What is tertiary hyperparathyroidism? If you could just explain that to the audience, and does it always require surgery? Thank you.
Oh, thank you. This is a very important question, and to make a concept of tertiary hyperparathyroidism, I always say tertiary hyperparathyroidism means the parathyroid gland is autonomous. It is performing their function at its own. Because the negative feedback loop is disturbed, the calcium sensing receptor is the most important feedback loop. But once the gland is fibrosed, so calcium sensing receptors lying in the PTH parathyroid gland is not they are not there. So gland is active and it is hyperactive, and it keeps on surging the hormone and releasing that hormone into the system. The problem is this the use of once there is a overactivity of PTH, we know that PTH will mobilize the calcium and phosphate load from the bone. On the other side, when there is a surge of calcium and phosphate in the serum, and on the other hand, PTH has to maintain a balance of phosphate by establishing its effect on the nephron as a phosphaturic hormone, but the patient has no output. Then whole the calcium phosphate product will start depositing into different parts of the body, like in soft tissue, the bone, even in the bones, and in the blood vessels, and in the heart valve. So I have seen the aortic valve like a stone hard, and we have seen the blood vessels like a rock, and very poor quality blood vessels, non-pliable. So basically, tertiary hyperparathyroidism means autonomous PTH gland. In our clinical practice, we prefer to send the patient to a surgeon for a night treatment rather Cinacalcet, because Cinacalcet has a lot of effects, especially it has propensity to cause dysrhythmia at one time. And the other problem is there is an issue with the absorption of Cinacalcet and cost effectivity, and the quality of life of the patient will not be that good as it will be after the surgery.
Okay, thank you very much. Thank you for a very detailed answer. Thank you, Dr. Mahmood. Dr. Farooq, a question for you. Recently, JAK inhibitors have been added in the treatment for rheumatoid arthritis. Please tell us about it. How effective are they, and when they should be started? Thank you.
So JAK inhibitors are a new biologic agent. They're considered to be one of the newer biologic agents that have been introduced in the care of rheumatoid arthritis. They can also be used in other types of arthritis as well, such as psoriatic arthritis. And they're very good treatments. I can't tell you off the top of my head how effective they are. I can't remember the exact numbers. But in terms of their efficacy, we have been having very good results with them. There are two types that we use. There are tofacitinib and baricitinib are the two main types of JAK inhibitors that we use. And in terms of when they should be started, we still use disease modifiers first, such as methotrexate, sulfasalazine, hydroxychloroquine, and leflunomide first. So those are the ones that we use first, disease modifiers. They're then the next step up. If a patient fails those treatments, so usually a patient with rheumatoid arthritis would fail 2 or more disease modifiers, one of which includes methotrexate if there's no contraindications, and they have a high disease activity score, which is usually 5.1. If they score high enough and they fail 2 disease modifiers, you then go up to biologic agents, and you can use JAK inhibitors first line. Now, TNF inhibitors were always the first line, the more traditional ones, but you can use them now first line. Well, obviously, it's always specialist initiation with the JAK inhibitors, as are the disease modifications as well.
Thank you very much. I hope, Usman Salim, you've actually got the answer. Farooq, another question for you. Painful and tender swollen joint, as an inpatient, whom should we refer first, rheumatology or orthopedics? I think I also get this wrong all the time, but yes, could you clarify? Painful, tender, swollen joint.
So it really depends on what you think the underlying cause is. If you're worried about septic arthritis, then it should be orthopedics. It depends on which services you have available, though, and where you are. You may not have an orthopedic service available in your hospital. You might just have a rheumatology service available at the hospital. The important thing is, if you're worried about septic arthritis, to try and get somebody that can aspirate that joint for you if there's a fluid in the joint, because that's what's going to hopefully give you the answer, preferably before they start antibiotics. So it's either a member of the medical team, or if the medical team can't do it, then please do discuss with rheumatology, particularly if you don't have orthopedics there. But if there is both rheumatology and orthopedics, we would usually recommend that orthopedics get referred to if you're worried about infection. If you're worried about the other common type that can cause it is gout, particularly in the medical patients. You know, they have crystal disease. If you're worried about crystal disease, then that should be referred to rheumatology. Then we would help you manage in terms of gout and helping crystal disease, and we could aspirate the joint, inject the joint, or give you advice on how to manage that. But if you're worried about septic arthritis and you think it's infected, then routinely it should really go to orthopedics if there's an orthopedic service available.
I hope you got the answer. Thank you very much. Again, very clear. Dr. Mahmood, Akbar Mahmood, you've got a question, and the question is basically calcium phosphate PTH. Why don't you just leave this for the endocrinologist to review and deal with? Why do nephrologists take interest in this? I know you've explained some of it, but just briefly, why is it not an endocrinology territory, and why is it renal that has to deal with calcium phosphate and PTH in CKD population?
There are 2 answers to this question. One answer is what you will say, professional statement. Professional statement is that this is a very specialized area of CKD, and probably being a nephrologist, you know, we have always sense of pride that we know medicine at par with most of the common specialties. So we are the better people to handle this thing. Honest, and this is one statement. The other spectrum, based on my clinical experience of maybe more than 15 years, referring such patient to endocrine people probably not come up with a good answer until or unless you should have an MDT meeting involving the surgeon with a knife into that meeting, that okay, we are going to give a trial for 3 to 6 months time, but you know, dialysis population, lot of other specialties are not very comfortable to deal with such patients. Yes, there is a role for endocrine people when you are dealing with the primary thing or sometimes secondary, but when GFR is less than 30 or people are on dialysis, so we always come up as a patient's advocate, and probably, I believe, as a nephrologist, we know it yet more than the endocrine people, like begging pardon to the endocrine people.
Okay, thank you very much. Farouk, I've got a question for you. Say, because one of your slides mentioned about, this is from one of the audience, one of your slides mentioned about NSAIDs in polyarthralgia. What's your advice to patients who have CKD and who cannot take NSAIDs for any other reasons other than CKD? Thank you.
This is a question to me?
No, to Farouk. Oh, I think his computer's frozen. We'll see if we can get him back, but I don't think I've got any other questions for you unless until audience, if you've got any questions you want to ask, Dr. Naqvi, can we unmute them? If you've got any questions to ask?
Yeah, and Mansoor, I have shared the CPD certificate link.
Yes, thank you.
Guys, you can click on the link and then and see your certificate.
Yeah, I think Dr. Mahmood, Farouk Mahmood may have actually come off the line, or maybe his computer got stuck. I have got no more other questions in the chat box that I had. Some were emailed to me privately. I've asked them all. Naseem, have you got any questions?
No, I have no questions. The certificate is being the link is being shared.
Yeah, so we don't actually do any
chat box.
certificates. So we don't do any certificates anymore. So please make sure before you turn off your computers, you do take the certificates. I will only do the certificates for the presenters. So Dr. Mahmood, Akbar Mahmood, and Farouk, I'll send you the certificates by emails. But everyone else, please copy and paste the link.
Thank you.
Yeah, so Jamaila is saying that valid in format. We just copy paste the link, please, in the browser, in Google Chrome or Safari, and it should open the certificate. It's a PDF format.
Okay, thank you very much. I think we should call it a day, Naseem. Thank you.
Yes, thank you very much, everyone, and we'll see you next time. Thank you.
Thank you very much. Thank you.